Welcome everybody to the Delaware CTR Tech Talk. Before we begin with our program, we have a few announcements. First, we will continue extending CME credits for our Tech Talks and for our Friday Innovative Discovery Series presentations. The information will be distributed now via email to those that registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Lisa Matoro at Christiana Care, and I will type her email address in the chat box so you can contact her. December 11th, so there'll be no ID series tomorrow, so we have our Tech Talk today, but next Friday, December 11th, we will have a community research exchange where we are going to hear from 4 COVID-19 themed project presentations that all kind of connect what we're doing with in the clinical sphere with the community, 2 from Nemours and 3 from our nurse research colleagues at Christiana Care. And TBD, save the date, our next Tech Talk will be January 7th, 2021. Yeah. So today we are delighted this afternoon to welcome Kimberly Carlson, who will speak with us shortly about leveraging Cerner real-world data and the Cerner Learning Health Network, of which Christiana Care is now one of, I think, approximately 50 member institutions, but I'm sure we'll get the real number from Kimberly soon. Ms. Carlson has a bachelor's degree in cell biology and microbiology from the University of Kansas, and a master's of public health from the University of California, Berkeley, where she focused in infectious diseases. Extremely relevant in the current times. I'm sure she's remembering all of that great public health information. She has a wealth of experience and has held positions in academic settings, nonprofit organizations, and worked at the California Department of Public Health before joining Cerner in 2018. She's currently a senior clinical researcher within the Data as a Service Strategic Growth Initiative for the Cerner Corporation. She leads several programs within Cerner. One of her many responsibilities includes managing the research opportunities and member relationships for the National Learning Health Network, which it leverages real-world data to enhance and accelerate clinical research. At Christiana Care, we are super excited to be a new member of this network, and I'm definitely thrilled to be able to bring this opportunity to the research community. I'm very excited to hear more. Thank you, Kimberly, and excited to hear your talk.
Thank you, Mia. Great to be here. I have the opportunity to speak to your researchers about how they can leverage the Cerner real-world data set and the Learning Health Network. Pull up my presentation here. All right. Okay, so why are we talking about this today? I just wanted to give you some background on what the issue is. So big data tools provide an immense opportunity for groundbreaking research and the development of predictive models in all fields, including health and medicine. And digital medicine really depends on the availability of large, heterogeneous sources of data. Now, we all know that clinical research studies can take many years, 10 plus years, and more than $1 billion to get to completion. But with the amount of real-world data that is available right now, we are very confident that this can greatly accelerate and enhance research in the clinical and life sciences space. So today, this activity will describe a large de-identified multi-center national EMR database that can be used for U.S. health research, and also describe a network of health systems contributing to the data set that can be engaged for clinical research. So we'll be describing this real-world data set, which again is national, de-identified, person-centric, that can enable researchers to leverage longitudinal record data from contributing organizations. You can access volumes of de-identified information for your retrospective analysis, for machine learning, for modeling, and your digital medicine research. We'll also be talking about the Learning Health Network, of which Christiana Care is one of the 51 members. So this is a collaboration of healthcare organizations throughout the United States that are interested in participating in research. They agree to contribute their de-identified data for approved research. We'll also be talking about our data science tools that are related to the real-world data set and how Healthy Data Lab, which is our cloud-based data science ecosystem, can be used to analyze data and do predictive model development with open source tools in there. Right, so we will be talking about these two different aspects today, and I want to make sure we're clear on the differences from the start. So Cerner real-world data is the national de-identified data set. It contains EHR data from more than 90 health systems in the US. And again, it's national, de-identified, and person-centric. So we have longitudinal records from all of the contributors. Our average dwell time in Cerner real-world data is about 3.5 years per patient record. And this is more than 2 times the industry average, which is about 1.5 years per patient record in that longitudinal record. And then the Cerner Learning Health Network is this system of 51 organizations currently that have opted in to contribute their de-identified data as part of those 90 health systems. So we have other health systems that are not in the network that are also contributing. And the network works in many different ways. So you have access to being a member of the network for free, but we can also bring clinical research studies to you. So here's a depiction of what the Learning Health Network is. It's this community of health systems throughout the US that contribute their data to enhance clinical research. And Cerner is doing all of the de-identification of the data on the back end. I'm not going to go too far into the technology behind that, but we're pulling it through the healthy intent record, standardizing it, normalizing it, and cleaning the data to make that de-identified national data set. The purpose of the Learning Health Network is to provide health systems and clinical research organizations, including life sciences companies and academics and health systems, with resources to more efficiently conduct studies that can help advance healthcare. And again, this is bidirectional, so you can bring, as a member of the network, you can bring research to the network as well, and we can bring research opportunities to you. Now, how would that work? So these are some of the benefits of participating in the Learning Health Network. Cerner is always out in the market looking for industry or grant-funded opportunities, and if we identify a good opportunity, we'll look at the data requirements for the project and see if your site is a good fit, i.e. has that population of interest that we're looking for. If so, I will send an email to Mia and Claudine and see if they would like to learn more. I actually did this a few times over the past few weeks with some opportunities that are coming down the pipeline regarding cardiovascular research studies. And then in exchange for you making your data available for a specific study, there would be a funding model or different benefits associated with each project. So there could be financial compensation, clinical tools. It really varies depending on the study sponsor and the opportunity. Now again, all members of the Learning Health Network receive access to the national data set, and we'll go into more detail about that national data set. So you get 3 logins to that national data set where you can conduct research. We actually just refreshed it, and it has 1.2 billion encounters in the most recent refresh from September. There's minimal technical effort or maintenance required. Cerner is just pulling all the data on the back end, so no IT lift for your teams are needed. And then the collaboration is something we're really going to be focusing on in 2021. We kind of used 2020. We just started this network in January of 2020. And since then, in that first 11 months, we now have 51 health system members nationwide in 25 states plus DC. So in 2021, we'll be focusing on enhanced collaboration of the network. We're actually going to be launching some communities of practice, which we'll be announcing next week to start, and looking for member input on what other types of communities of practice we'll be bringing your way. So you all can learn from each other, work together, and collaborate on research, which I know Christiana Care is very familiar with. So the data security and protections are very important to us. You have granted us data rights for specific use, and we have many types of security in place to make sure that we protect that data for that use only. So we'll go into more of these a little more in the next couple of slides, but use of data for research is only for approved research proposals. This is overseen by the Governance Council. All data is fully de-identified, and we'll go a little bit more into that in a moment. I'll show you some of our de-identification algorithm. It's all housed on the AWS cloud. We can audit all activity there, and no data is ever to be downloaded to personal computers, and no health systems are to release any individual system information without approval of others. So we do have some members in the network that have agreed to work on different collaborative projects, and you are allowed, we can tell you what your site identification number is, and if you were working on a collaborative research project, then you could draft a document to share your site IDs with another organization to work on that specific project, but totally up to you. And all sites are anonymized, providers are removed, and all PHI is removed. So the Governance Council is something that we think makes the Learning Health Network a little unique. The Governance Council is tasked with overseeing that the use of data is ethical, confidential, and representing the best interests of patients, providers, and member organizations. So making sure that the research proposals are in good science and really will benefit patient health, clinical health, and really inform science as research studies. So the Governance Council is comprised of representatives from Learning Health Network member health systems, currently 3 members from member health systems, representatives from academic research, an ethics or privacy research expert, a patient advocacy representative. We're actually still looking for that candidate, so if anyone has recommendations, please send them my way, because that's a perspective that we would really like to be represented, and a Cerner leadership representative. But the point here is that the members are the ones making the decisions about what research is conducted with their data. So every time a data access proposal is submitted to the network, I take that information, blind all identifying information, and route it to one of the member representatives for review and approval or further discussion or denial. So how does this work? How are people submitting a data access proposal? And when do you need to do that? This is some guidance that we recently drafted to help you decide when your organization needs to submit a data access proposal. Because whether it's a life sciences company, a member organization like yourself, or an academic institution, data access proposals are required in certain circumstances if you want to have access to the data set. Although you already have 3 logins to the data set, if you'll be conducting research on that, we would like to see what that research is involving. So LHN investigator initiated is a section that you would be looking at. So if you're just looking at information for your own site data, for your own internal purposes, and you know your site identifier that we provided to you, you do not need to submit a data access proposal. If you don't plan on publishing, you're just doing QA projects, also again, you do not need to submit a data access proposal. If you're preparing a research review or thinking about things for a grant proposal, that is not needed as well. But if you were to ask us for a letter of support or a letter of interest to submit with your grant proposal for, for example, NIH funding, and you plan to really leverage the data set in that grant, that is something that we would like to, before we would provide the letter of support, we would want to put that proposal through the Governance Council there. So that's an exception there. But anytime you're doing multi-site queries on the national data set or conducting specific research projects, we would like to see that data access proposal go to the council for review and approval. And then the external life sciences fill out the same proposal. It's really just a very simple 1-page document. When it's complete, maybe up to 2 pages, just a study title, a summary of data points of interest, expected outcomes, etc. And you can access that on the Learning Health Network community page in the data access folder. You just download a blank proposal, complete it, and send it to me. And then I blind all identifying information, so the Governance Council doesn't know if industry is submitting this, if a Learning Health Network member is, if an academic institution is. And then they turn around that review usually in 2 business days, or if they need further time to discuss it with the full council, it could take a little bit longer to coordinate that, but really it's been a quick turnaround time. And we've reviewed 15 proposals thus far this year, and all except for one have been approved, and that was because it was way too broad. So we don't like granting access to the entire data set for unspecific projects. We really like those focused research questions to look at specific aspects of the data for a specific reason. So I mentioned that you can access the data access proposal on the Learning Health Network community page, and you can actually do much more there. So here is the web link for that. It is what was formerly called a UCERN group, and now they're calling it a Connect group. But here is that web page, and you can use this page if you don't have a Cerner Care account. There's information here on how to set one up, so anyone at your institution can do that since you are a Cerner client. And here you can find all the information that you want related to the Learning Health Network. So you can go in and look at the Governance Council Charter. You can find those data access proposals. You can find our data de-identification algorithm if you want to file that with your IRBs. You can find information about the national data set. Healthy Data Lab is our data science environment. You can find our training webinars there. We have 7 training webinars about how to interact with that data set using the available open source tools. You can find recordings of our meetings and events. We have quarterly meetings with all the members of the network, and it's actually next week is our next quarterly meeting. Slides and recordings, and then our bibliography pages. So here, Cerner Health Facts is our legacy data set that was used for over 20 years that we actually used to mail a hard drive of data to our clients with millions of patient records on that. So definitely Cerner real world data on the cloud is an enhancement to that, but that resulted in over 200 peer-reviewed publications. And then now we have new, smaller, so far published bibliographies for Cerner real world data and for Healthy Data Lab. We're also actually launching a new Cerner Publications research web page next week. So look for that, and that's where you can go and find links to all of these publications that will link to the journals that they're published in. You can also communicate with other members here. That's been limited thus far as we've been growing the network, but we'll be housing the communities of practice here, and hope that we can grow that collaboration and communication between the network as we move into 2021. All right, so I've mentioned our data de-identification. We follow safe harbor guidelines for de-identification of health data, and sometimes go even beyond that. So Safe Harbor says that you can have zip code down to the first 3 digits of zip, but we actually take it one step further, and for this data set, we only go down to the first digit. So you can only see those geographic subdivisions smaller than the census division are not extracted for real world data. So that breaks up the United States into 9 areas. All PII is not extracted for real world data. It is primarily discrete data, but we are continually adding more data enhancements, and that is a big focus of next year as well. So we're hoping to get more down to categories including whether it's an urban or rural area, and we're starting to add some survey questions, so things like PHQ-9, etc., that could be useful to you, more information on substance use, etc. Okay, so here is a snapshot of what the national data set includes, and this is very slightly outdated. We did just finish that late September refresh, and we are updating our slides to reflect the new numbers there. But as I said, we now have 1.2 billion encounters in the latest refresh there. But this was a slide from earlier in the year, so you can see the very wide breadth of data that is available. 450 million outpatient encounters, 18 million inpatients, 48 million emergencies, 6 million microbiologies, 11.5 billion labs and immunizations as well. So a very, very large data set. And here's a snapshot of, here you can see on the map how that 1-digit zip is pulling the data there. So the data is actually a little heavier on the West Coast, but we do have a really good national distribution, including data from all health systems. And again, this will be updated since we've added more contributing health systems in the most recent refresh. here's our race distribution of data, gender, ethnicity, and observation period in years. So how are we pulling that data? As I mentioned before, we're really just pulling it as a byproduct of your clinical care through the Healthy Intent architecture. Healthy Intent is our cloud-based population health platform that collects any type of data, not just Cerner EHR data, so any type of data can be added to the data set. And then we aggregate and normalize it in a structured way. And Healthy Intent is ensuring that that data from different sites across the US are speaking the same language. So we do that cleaning, standardization, concept normalization, person matching, and then apply that de-identification algorithm to create different data marts. I'm not sure if your organization has been working with the COVID data set. That is something that we made available earlier this year for researchers. So there we have taken a subset of the National Cerner Real World Data Set and collated all COVID positive patients that could be used for research there. And we plan to be organizing additional types of data marts like that that are focused on different therapeutic areas and putting those into the real world data area for you to analyze next year if you want. And then we make that data available to you via Healthy Data Lab. So what is Healthy Data Lab? It is our data science ecosystem. It's built on Amazon Web Services, and it includes open access to open source tools, including Apache Spark, Jupyter, Python, Spark R, PySpark, and Spark SQL. So as I mentioned earlier, each Learning Health Network member receives up to 3 logins to access Cerner real world data in Healthy Data Lab. This is actually a shared community domain, so all of those 51 members are using that same shared environment. The open hours are, I believe, 7 a.m. until 10 p.m. Monday through Friday. So all three logins can be in there as much as they want during those open times, but we would not want one login, one username to be shared and in there at the same time. We understand that larger research organizations, the usernames might be shared through different departments, and we'll be working on setting this up for you soon. I believe your data network agreement. So we do have one document that is in between you and the data right now. It was released by our legal team a little bit later, but it's called the Data Use Agreement. So it's basically the rules of the road for interacting with the national data set, saying that anybody at your institution that is using that national data set agrees to use it as directed, which includes many things like not downloading the data, not trying to re-identify the data, etc. So we hope to have that signed soon, and then as soon as that is done, we will set up your 3 accounts. Now, if you find that this environment is that the demand of your researchers is well beyond the 3 logins that are available to you as part of the community domain space, there is an option to add your own private Healthy Data Lab environment, which can allow for additional users as many as you want. And we would just put the national data set there, and you could also load any additional data sets that you want into that private space. So that is an option, but I think for now, a lot of our members are just getting started with the 3, figuring out how to best distribute those logins at their health system, and then seeing how it goes for the first few months or year, and then we'll determine whether they need enhancement in their own private space. All right. I know I went through that very quickly. So here's my email, and I am happy to clarify any of the information that I have presented and answer any questions that you have.
That's excellent, Kimberly. As we're waiting sort of for people to ask questions, I put in the chat, but just so everyone is aware, we do have 3 ongoing projects with the COVID-19 database. Claudine can speak more to the details as to where we are with those projects, but very exciting. And we've already had one I think collaborative with our Heart and Vascular Institute that they are moving forward with. So it's been quite productive from our perspective, just in the past few months that we've been a member.
Awesome. Very glad to hear. Okay, just looking in the chat. So yes, I'm happy to share the slide deck. I will send that over immediately after. Are children patients included? Yes. We have less pediatric contributors than adult contributors, but I believe some pull up. But he just told me the recent update on numbers on peds, but yes. Will this source be available for IRB use by residents? At other sites, this is completely up to you and your research operations. We do have residents at other institutions that are using it for their specific projects. So if your research team decides that that is appropriate, then yes, we welcome your research proposals.
And so just to clarify, so then a resident would, as you said, have to write a proposal that would be reviewed under the governance committee still, right? And then
exactly, that's how it worked. Yep, at our other institution.
And then we have 3 logins, you said. So just, it's sort of within the Value Institute, we have those 3 logins, which basically means that you can run 3 projects. It's like, I guess, 3 projects at a time, but no more than 3.
Or split up the hours as well, since it's open from 7 a.m. to 10 p.m. But every institution is doing it differently. Let's see. Do you have any relationship to the U of Cincinnati LHS organization? No, we do not. Not yet.
And this is Claudine, if I may add also to the question related to the residents. I mean, researchers need to have special skills to be able to work on this data, because the only programming tools that are there are R and Python and Spark Python, I think, and Spark SQL, sorry. So, they are very specific programming tools. So I'm not sure, most of the residents would not know these tools.
Great point. We do recognize that it is a tool that is more for advanced data science personnel right now, and we do plan in 2021. We know that this is a limitation, especially for some of our small and the mid-size health systems throughout the U.S. They don't have those capabilities in-house, so we plan on offering some additional data visualization tools that will be for personnel that don't have those data science skills. But there's definitely a way, I think, to, if a resident was somebody to propose a research concept, if there was an analyst at your institute that had available bandwidth to conduct the queries of interest, that could work. Can you describe how the statistical tools interact with the data source? If a researcher logs on, do they have access to use R to interact with that data? What might a SAS user do with this? So SAS is not an available tool in this platform. The tools that are available are Apache Spark, Jupyter, Python, Spark R, PySpark, and Spark SQL. So you have to, in the Healthy Data Lab space, those are the tools that are available.
So that's what we were saying, where you really need specialized statistical or data science skills. If you don't sort of know those languages, you either have to learn it or find someone who does. So if you're a Stata user, or SAS user, or SPSS user, it's not that simple.
So it's a good opportunity for team science.
That's for sure.
Okay. Let's see. Many of the databases do not have reliable mortality data. Is this true for your database as well? I mean, mortality data is always sometimes incomplete, depending on whether somebody, this data set is definitely strong on inpatient data, since that's where a lot of the data sources are coming from. So if somebody is passing away in the hospital, obviously we'll have that. But I think in general, I don't think it's like a huge weakness, but it's just to be expected with mortality data that there's going to be a lot of incompletes out there because of where people pass away.
Kim, do you know if people have used this data or tried to kind of merge it with the National Death Index or other kind of?
I am not sure on that. That's a great follow-up, so let me check in on that. It really is, let's see. I would assume, but yeah, let me follow up and get back to you on that.
That'd be great.
So do you code in the system, and does your code live in this system? Yes, so there's folders for each organization. So you would use the login credentials that we would set up for those 3 accounts. You would log into the system. There's a folder for each organization in there, and then you would be coding in that kind of folder and data space there and saving your work there. Now, there are a lot of restrictions about not downloading the data, but we know that a lot of people need to download for publications and presentations, etc. So people just work with our data engineering team there to facilitate that. So there are ways to download the data. It's just we don't want the data downloaded to personal computers for analysis.
So you mean you can download the aggregate data, like the results of the analysis, but you're not saying download the actual like individual level data?
Right, and even to download the aggregate data, you need to work with our engineering team. So it's, letting them know what you need and why you need to download those tables.
Right.
And we're happy to do that. Great questions.
I have another question, if I may. This is Claudine again. You mentioned external institutions could have access also to this data. We work a lot with our colleagues from University of Delaware, for example. How would it work if we wanted, them to access this data? And I didn't know that other institutions that didn't participate in providing data could also access the data.
Yeah, so any institution, life sciences company, academia, or health system can submit a data access proposal for access to the data. There's different pricing and availability for academic institutions versus a life sciences company, but there are some ways that some of our health systems that are associated with academic institutions, so like you were describing, that they could, if you agree to use your login with them and their statisticians to work on a specific project. Again, that data use agreement that is being routed currently at your organization is saying that anybody that is using your login is going to obey the rules of how to operate with the data. So that is allowed, but they can submit a proposal on their own as well. And if they just wanted to purchase an individual login, then that is an option as well.
So it means cost. It means there is a cost to access the data for other institutions. That's what you are saying.
Yes. But academic pricing is different than life sciences. But if they wanted to come on, if you were working on a project together and wanted to let them use one of your Christiana Care logins, then that's an option as well, with your oversight.
Okay. This is where I think the Delaware CTR, which is this network of, both academic and our healthcare system, and Claudine, to your point, like the value of team science is really kind of working together so that we have an academic partner within this network. We have our analysts at Christiana Care, we can partner together in this space. Or we can also use the CTR pilot mechanism. So pretty soon we'll have an RFA that will come out asking individuals to write pilot proposals that will be due in March. As part of those pilot proposals, people could utilize this data and then ask for the funds to have their own access.
That's a good point.
Yeah, great.
It's exciting.
There's definitely some flexibility there, and this is common across the country that, health systems are connected. So some institutions are kind of allocating one of their logins to the academic institution, depending on their relationship. We refresh the data quarterly as well. I don't think I mentioned that. So always working on enhancements and then adding more patient lives. Anything else that I can clarify? Had some great questions so far.
And our own Robert Asante, I think Robert sits on the governance council, right?
Yes. Oh, I forgot to note that. I'm sorry. Robert, if you're on,
No?
hello. Very excited to have Robert and his expertise on. We just joined the council recently, and he's already completed a review of his first proposal in the past few weeks. So we are absolutely thrilled, and he's been a joy to work with.
And just so everyone on the call is aware, at Christiana Care, we have an internal working group. So Rob, Lynn McCone, myself, Claudine, meet every few months. I don't know if we meet quarterly or every other month. I don't remember. But just to kind of review things and make sure everything's working. And obviously, we have a great relationship with Cerner and with you guys. So it's been really great. If you have questions, you can reach out to, I think, any of the four of us.
So if there are no other questions, I still have other questions. COVID related. So as Mia mentioned, we have 3 projects right now, that are COVID related, for which we use the current COVID database. I know that the access to this database is going to close in December. However, December 31st. However, because we are part of the Learning Health Network, we will still have access and all the data will be transferred, that's my understanding, to the large Cerner database. So will the COVID information be also refreshed quarterly at the same time as everything else, or is all the COVID information now basically closed once it merges to the large database?
I would expect it to still be refreshed. I think it would be remiss to not, but I believe there is an update call this Friday, so they'll be going into details of that. But yes, as you mentioned, they will be moving that data set to the real world data community space for you to access there. So very glad to hear that, but that team has been working on the exact specifics of the COVID set. So please ask that on Friday if you're there, and if you're not able to join, then I will ask on your behalf.
Thank you. I think
the frequency of refreshes are. Yep.
Okay, thank you. And related to the private access or setup that we could have to have more logins, is it something also that for which we would need additional funding, or is it something that we can just ask and have access to that, or how would it work?
So right now, there is a cost associated with that. There's a one-time setup fee, and then for each what we call seat or login, there's a cost associated with that per month. But we're also just in the first year of the Learning Health Network, so we'll be evaluating, if we are hearing from a lot of our members that these 3 logins are absolutely not enough, and then we're seeing that some of our smaller health systems are not using the data set at all because they don't have those data science skills, then we're definitely open and will be reevaluating on a regular basis whether we can increase that, because we just want to make sure that the data space is functional for you all and you all are able to conduct your complex querying without any lag time. So, yes.
Thank you.
Okay, actually, I have a question. If, say, there is a researcher who's interested in a particular topic, writes the proposal, but doesn't have those skills, is there a way within the network to, ask if there's someone, maybe a researcher at a different partner institution that has those skills that would want to partner, looking for teams around projects that go beyond just maybe your local area resources, but using the network to connect? Do you know what I mean?
Yeah, I mean, we're definitely hoping for that type of communication and collaboration in the future. It hasn't, like I said, this year has been more about building the network and less collaboration. But I think especially as we launch these communities of practice for specific areas, it'll be a great opportunity for more of that teamwork. And a lot of people do submit, including our life sciences companies and academia, people looking at grants, they submit their research ideas and then they spend the next month or 2 or 3 looking for that PhD student that can help them, do the coding. So that's kind of, our resident submission that we had from academia was similar. Like, he doesn't know how to do the coding. So he had to go look for somebody that could partner with him that could do the coding and collaborate on that project.
Can you talk a little bit more just briefly about the communities of practice? Really interested in what the vision is for that.
Sure. Well, you'll be hearing a lot more about it next week, so I'm just giving you a preview. Don't tell. But communities of practice are ideas it is a concept that was started in 1991, I believe, by some researchers, Weiner and Tregner, and it was about how people with like interests can really learn from each other. So the first 2 that we're going to launch are pediatrics and rural health, but it's really just a volunteer basis. If it's something that you are interested in, how can you learn from each other, best practices, collaborate together, talk about what's going on in your part of the country versus another part of the country, what's working for you, like telehealth, what's been great to reach your patients. I mean, just anything, it's related to shared interests, but it's not, the concept is that it's not led by like me, it's our members group and to learn about whatever they want to learn about. So there could be presentations, but it's really that shared learning aspect and leveraging that collaboration to work on whatever is of interest to the community. But it's been very successful in many different types of health areas. So different than kind of a subgroup, and it exists as long as you want it to exist and is as great as the members put into it. We're there to supply the coordination and the space for it, but we're hoping that a lot of people can connect on shared areas of interest and really open to other categories that we can branch off of. But we thought these were 2 that were good to start with.
And do you see like it as a place really where you could also have that translation of research or research findings into practice as you have this? Yeah.
Absolutely. The implementation science part is very key, in the clinical system, and especially this is a research network, but it's so difficult to get those research findings filtered down into actual clinical practice. So again, sharing like what are the best ways that you do that. In my previous work, it changed so much over the past decade of how people want to ingest that information. People are just too busy to read journal articles, and everybody actually wanted podcasts of 15 minutes or less that they could listen to on their commute. So meeting people where they are.
That's exciting.
Any other questions from the group? I'm so glad so many of you could join us, and we hope that you find this national data set to be of great interest and your wheels are turning of how you can use this for your work and the work that you would like to do. So I am always here to answer any questions. My email's in the slides, and me and Claudine know where to find me as well. So we are so glad that you're members of the network, and we look forward to you leveraging these research solutions for the important work that you do.
Thank you so much, Kimberly.
Thank you.
Thank you all. Have a great day.
Thanks, everyone, for joining us.
Bye.